Hello everyone. We are really apologize for a technical glitch that we had in our video, and some of you couldn't see the video, and we are starting off again. Uh, so we have with us a leading psychiatrist, Dr. Sachin Arora. He's a consultant psychiatrist at the Metro Hospital. We're really glad to have him here. He's also a renowned faculty at GAMS. More than every year, more than 30,000 students get benefited from his work, from his teachings, and their preparation for the entrance examinations. Really glad to have him here, and I would hope you get great benefit out of his sayings today. Over to you, Dr. Sachin, from here.
Thank you, Mr. Pawan. So thank you for giving me this opportunity. For the students who don't know me, I am Dr. Sachin. I'm psychiatry faculty at DAMS and practicing psychiatrist at Metro Hospital, Preetpya, New Delhi. Today I am live here on the Curofy platform and on my page DAMS Psychiatry. The topic I have selected for today is mental health basics for doctors. So this is a platform, Curofy. On this particular platform, there are more than 2 lakh doctors. So I wish to discuss psychiatry, some areas which I always wanted doctors to know. Doctors, by that I mean non-psychiatric professionals like medicine for doctors, family medicine, surgeons, orthopedicians, and especially the MBBS doctors, my students. So today I'll discuss some mental health basics. A theme of today's talk was WHO depression. Let's talk. Before I talk about depression, what I feel as a doctor, a psychiatrist should know will be discussed first. Then I have got some queries which have been sent to me through Curofy platform. I'll discuss the queries which have been asked to me, and the session is live open. So whatever queries you are getting regarding psychiatry, we'll take care. Just give me 15 minutes in which I wish to explain to you how much psychiatry and MBBS doctor should know. First thing, psychiatry MBBS doctor should know is minimum is how to detect a psychiatric illness. When to call it as a psychiatric illness and when not to call it as a psychiatric illness. That is the warning signs of a mental illness. You are sitting in an OPD, you are seeing a patient of diabetes, you are seeing a patient of rheumatoid, you are seeing a patient of cancer, you are seeing many patients. Many times when the patient expresses to you, doctor, I don't feel like life is good. I don't feel happy. I'm not happy for so and so reasons. Now, whether it is depression, whether it is not depression, you are not sure. So please don't go by the layman terminologies of depression. Sir, today I am feeling depressed, and you say that if your patient is depressed, refer to psychiatrist. When to refer the patient to psychiatrist and when not to refer, that is something I wanted to tell you. There are normal reactions of the mood with respect to the environmental or the physical state. For example, when we have fever, we are not happy. That doesn't mean we are depressed. For example, when we have some medical illness, long-standing medical illness, we are not happy. That doesn't mean we are depressed. So what is depression? Depression is not just sadness. First point to know. Depression is not equal to sadness. Depression is depression. Sadness is a part of depression. Sadness is a part of depression. So depression is a disease. Now, depression can be mild, moderate, or severe. First thing I wish to tell you is that mild depression can be managed by MBBS doctor, PHC setup, and non-psychiatric professionals as well. You need not refer all cases of mild depression. And it's actually, if you refer, it's good, but what is happening is you refer the patient to a psychiatrist, and because of the stigma associated, not all of them are reaching to the psychiatrist. So as a doctor, you should know by means of this video how to manage mild depression. Even WHO says that for mild depression, MBBS doctor can manage. Because many of the patients are going untreated. How will you detect depression in an individual? By the presence of 2 out of 3 symptoms, which I always teach, which I always tell. Low mood, that is sadness. Anhedonia, that is decreased enjoyment in previously pleasurable activities. And third, decreased psychomotor activities. 2 out of 3 symptoms must be present for a minimum period of 2 weeks in order to call it as a depression. Not just depression, you should be able to detect and screen whether the patient is having any psychiatric illness or not. What are the signs of psychiatric illness? Behavior abnormality. What do you mean by behavioral abnormality? Like when you get angry, you throw away the things. When you get angry, you shout. But a patient having a psychiatric illness shouts with or without a reason, throws away the things with or without a reason. So behavioral abnormality amounting to a psychiatric illness, is that something you need to look after. Then the third important management of one thing which an MBBS doctor should know is insomnia. decreased sleep is a commonest complaint of a patient having a psychiatric illness, or maybe even without a psychiatric illness. You have a patient of diabetes, you have a patient of any medical illness, and he says that I cannot get sleep, sir. Do you think if a patient of yours says I cannot get sleep, will you refer him to me or any other psychiatrist? I don't think so. That's required. There are two types of insomnia in psychiatry: primary insomnia without a cause, secondary insomnia with a cause. Most common cause of insomnia that is not able to sleep is anxiety. So anxiety, that is the most common cause of insomnia, which we call as in Hindi becheni, restlessness, घबराहट. You, prior to the exam night, you are not able to sleep. That's a secondary insomnia, not a primary insomnia. What is primary insomnia? Is the insomnia without a cause. Treatment of insomnia says is treat the underlying cause. But first, take home message for the day for doctors: don't manage insomnia always by anxiolytics like Alprax, Zapiz, Itizola. I mean to say alprazolam, clonazepam, itizolam. Don't always give them. These drugs are likely to produce dependence, and you need to understand what is the basic difference. There is a concept called sedative hypnotic. A drug which brings a hyper person normal is called sedative. A drug which takes a normal person asleep is called hypnotic. And every sedative in low doses is an hypnotic in high doses. For example, now you are listening to my video, you are not anxious. If I give you clonazepam, you will sleep. But on the day prior to the exam, if you are coming to me and I'll give you clonazepam, you will become normal. So hyper person becomes normal by sedative. A normal person becomes asleep by hypnotic. And every sedative in low doses is a hypnotic in high doses. So you need to understand one thing, that we need not prescribe sedatives to all patients. This is one thing MBBS doctors and other professionals should note. That it's very easy to make the patient feel better by giving itizolam and clonazepam. But when these drugs are given regularly, they produce dependence. So for insomnia management, we have better group of drugs which are non-dependence producing, which we call as Z group of drugs like zolpidem. Second thing, always look for presence of a psychiatric illness even in a medically ill. There is a concept called consultation liaison psychiatry that comes as an MCQ also in PG entrance. That is psychiatric illness in a medically ill. Suppose you are an endocrinologist, there is a patient of long-standing diabetes which presents to you and says that, sir, I don't feel life is worth living. I feel that rather than referring to the psychiatrist, endocrinologists, medicine doctors can start the antidepressant themselves. Now, while starting the antidepressant, the drug of choice of first line of depression in guidelines is SSRI, selective serotonin reuptake inhibitor, which can be started by an MBBS doctor as well, and which can be started by an MD medicine as well. So why are we giving SSRI in depression? Why are we giving SSRI? Because there is a serotonin depletion in depression, and that's when we replenish the serotonergic stores by means of reuptake inhibitor. It helps in depression. So always look for psychiatric illness in medically ill if the patient expresses to you. Second important thing MBBS doctors should know about psychiatry is psychiatric emergencies. The most common psychiatric emergencies are confused, disoriented, and violent patient. You must know how to evaluate it. Always look for presence of organic factors, that is causative things like head injury, substance use first. Then think of a psychogenic cause. Second thing which an MBBS doctor should know about psychiatry is drug reaction. A patient of psychiatry many times becomes serious and fatal because of drug reaction. The two commonest drug reaction which I feel MBBS doctors should know is neuroleptic malignant syndrome and serotonin syndrome. Neuroleptic malignant syndrome is caused by antipsychotics. Suppose you have a patient who is on a psychiatrist treatment and he presents to you with fever, take home message. Patient on psychiatric treatment, drug treatment, presents to you with fever. Be careful, check for rigidity. The patient may be going, maybe, not always, may be going for neuroleptic malignant syndrome, which is a very dreadful complication. Similarly, when a patient is on antidepressant fatal complication, SSRI fatal complication is serotonin syndrome. So take home message number 2. When a patient is on antidepressant, look for diarrhea, flushing, excessive sweating. Diarrhea, flushing, excessive sweating, patient may be going towards serotonin syndrome. Maybe. I'm not telling about the diagnosis. I'm just telling about the warning signs. So first take home message was look for a psychiatric illness in a medically ill. Insomnia management was the second take home message. And the third take home message is drug reaction. Then the next medical emergency which doctors should know is about how to handle a suicide attempt. How to handle a suicide attempt case? Yes, genuinely speaking, every suicidal attempt case should be referred to a psychiatrist. But the emergency management of suicide, please ensure safety. Prevent the further suicide as far as possible. Always advise the attendant for 24 hours observation of the patient, because it is always mandatory. And don't take any suicidal threat as non-seriously, because it is a myth that people who actually commit suicide do not give prior warning. They do give prior warning as per the studies. So don't say that he or she is just saying that I'll commit suicide just to draw attention. By rule, every suicidal threat should be taken seriously. Next thing I would like to talk about is the common psychiatric illness which presents to an MBBS doctors are depression, anxiety, and somatoform. Somatoform is a case which will trouble you many times. Person having many somatic complaint and you are not able to find a cause for it. For example, any medical illness, you do investigations and investigations are not coming out to be positive. So in that case, even if you diagnose somatoform, never say to the patient that your illness is psychological causation, because the patient doesn't like to hear that particular word, and you can manage these patients by SSRI or tricyclic antidepressant. So there will be one patient in your OPD who will be having a chronic pain-like syndrome, not responding to NSAID much, not responding to opioid analgesic. Think about somatoform. Then I would like to utilize this time more for basic knowledge of drugs used in psychiatry and their common observable side effects. Basic knowledge of drug used in psychiatry are for a spectrum called psychotic disorders, which includes schizophrenia, delusional disorder, acute psychosis, schizoaffective disorder. All these are considered psychotic disorder. What do you mean by psychosis? One meaning is insight is absent. Patient doesn't consider himself to be ill. And second is loss of reality contact. So, for a psychotic disorder, we use a drug called antipsychotic. Why? Because in psychotic disorder, dopamine is increased, antipsychotic decrease dopamine. So, more or less, they are the mainstay of treatment. Second group of drugs which you should know is antidepressant. Antidepressant, the major classes are selective serotonin reuptake inhibitors, tricyclic antidepressant, serotonin norepinephrine reuptake inhibitors, and some others. So, basic is depression is a disease believed to be caused by trimonomanergic depletion theory. So serotonin, norepinephrine, dopamine are depleted. So when we increase these SSRI, SNRI, NDRI, the depression stores are replenished. There are 2-3 things which you should know about SSRI. Number one, not all SSRI cause dependence, and there are very less dependence producing as believed otherwise. So never think that all antidepressants are sleeping pills, which many times the patient will ask you that are your drugs going to make me sleep? Not always. So I have seen that MBBS doctors and MD medicine doctors, they are using something called as SSRI plus benzodiazepine combination. Me personally, and I personally as a psychiatrist, prefer to give SSRI and benzodiazepine separately, meaning thereby, because SSRI has to be continued for a longer period, and combination, that is clonazepam, metizole, and benzodiazepine are given for a shorter period. Third thing which you should know about SSRI is that SSRI, how long the treatment is to be continued for depression. Normal course of depression is 6 to 9 months. So at least for a period of 6 to 9 months, antidepressant must be continued. Your patient is likely to stop antidepressant after remission of symptoms or after recovery, 1 to 2 months. And it is written in the textbook of psychiatry that if a patient stops antidepressant within 3 months, there is a very high chance of relapse of the symptoms. Please remember all these things. The commonest side effects of SSRI are GI side effects. Sexual side effects are completely reversible on stoppage of drugs. Don't worry about the sexual side effects. GI side effects are there, of which tolerability develops over a period of time. You need not worry too much about GI side effects. Yes, sometimes SSRI cause insomnia, like fluoxetine. Some of the SSRI are activating SSRI, but that too we can avoid by giving fluoxetine in the morning rather than giving it in the evening time. Third group of drug is, like I talked to you about, anxiety management, benzodiazepine. Benzodiazepine are sedative, hypnotic. The concept which I just talked about, benzodiazepine should be given for acute anxiety, panic attack, and for short-term period of management of anxiety. And the fourth group of drug are which we use less likely in a disease called dementia, anti-dementia. This is the basic knowledge of psychiatry which an MBBS doctor should have, according to me. I tried to summarize the psychiatry basics for an MBBS doctor. There are many more things, and I cannot discuss all of it in this particular time period. Now I would like to take up the queries which have been asked to me over the last 24 hours regarding psychiatry. First question asked to me, sir, Sir, what is the treatment of adjustment disorder and how can we take this patient to psychiatrist without any force? How can we make him that he is suffering from disorder and hampering his social life? Let's understand what is adjustment disorder. Adjustment disorder is a reaction to a stress. So after a stressful situation, that's called adjustment disorder. After a stress, the person is depressed, for a particular person is having mild to moderate depression, that's called adjustment disorder. If you have diagnosed that the person is having adjustment disorder, first thing that you require is to help him understand the causation of the illness. It is caused by excessive stress and less coping to that particular disease. If he understands that, he needs mainly interpersonal or supportive psychotherapy and some antidepressant, and you can convince him that by taking this treatment he will feel better. Next, how can we prevent schizophrenia if it's running in your family tree? Yes, schizophrenia is a disorder in which family and the genetic history are important. There is no as such sure shot preventive techniques for schizophrenia prevention, although there is a prodrome of schizophrenia being talked about, of which there are many things being talked, like prevention by use of some omega fatty acid, prevention by use of certain drugs, but these do not have a confirmed and clinical evidence. So this prevention part is not very clear as far as the textbooks are concerned. There are research going on in this particular. Although the one thing which you can tell to the schizophrenia family member relative is to control their expressed emotions and to manage the stressful situation more effectively in order to prevent from a psychotic breakdown. Then, how long the treatment of panic attack should be continued if the patient is on SSRI? Patient had history of infrequent episodes of panic attacks in last few years. So the question asked is, if a panic attack treatment will start SSRI, how long it is to be continued? Again, the panic disorder is recurrent frequent panic attacks. If the frequency is not too much, you can tell the patient to use benzodiazepine on SOS basis. Although the long-term treatment for panic disorder is SSRI, it should be continued at least for a period of 6 to 9 months. If the attacks are infrequent, you can taper and stop SSRI and advise the patient to continue benzodiazepine on SOS basis. Any food items which promote serotonin in the body? Yes, it has been there. Some of the food items which have been talked about, but evidence is not very confirmed, not very sure. I cannot say that if you have serotonin depletion, take bananas and you will get out of depression. That is something which is there in the research. There is the nutritional theory of depression also being talked about. Like they say that some of the methylcobalamin deficiency, there are TPP related, but these are not very confirmed methods. So we do not advise that things, although there are studies that these things have more serotonin. Because what I say is serotonin depletion in depression is more in the CSF and not in the blood. Do not get that blood serotonin depletion, it is more in the CSF depletion of serotonin. Then what should be the treatment and management for quitting smoking in a chronic smoker, 6 to 10 cigarettes per day for 6 years after failure of psychiatric counseling, nicotine chewing gum and tablet Bupropion XL, that is bupropion. So I've been asked a query by some doctor. He said asking that how to quit smoking with Bupropion XL and psychiatric counseling and nicotine chewing gum. In nicotine chewing gum are tried in good enough doses. Bupropion in good enough doses, that is 300 milligram, has been tried for a significant dose duration. The third option which we have is varenicline. That comes as a tablet Tempix by Pfizer. That's a good alternative for quitting smoking. Although it's a costly treatment, but it has good rate. My question is that how a person with depression can get over it. I think just medication is not sufficient. What is the role of family and friends and how much? Yes, good question. The question is, how can a person get out of depression? Medication is not enough. Medication may not be enough, but medication is the mainstay of the treatment. Along with medication, we do psychotherapeutic treatment by a psychiatrist, cognitive behavioral therapy, or if there are some problems in the family relationship, interpersonal therapy that can be done. But there's a role of family members in depression also. We have to teach family members how to behave with a depressed patient, like we teach in family members how to behave with the schizophrenia patient. That's what the WHO theme was. Let's talk. Why is that particular thing? Let's talk. Because when we have piled up emotions and we don't ventilate, it leads to frustration, and frustration ultimately leads to having sadness of mood, and the cycle goes on. So more we ventilate, more we are comfortable. So that's why the theme is let's talk. If you have a patient who is depressed, the first and the foremost thing you have to do with him is listen to him. The more you listen, the better you listen to him, the better is the patient. The better is the patient. So, is counseling sufficient to cure depression? What is the role of counseling and medicine together? If one of them is not given, then what is the result in depression? I always say that depression has to be a multifaceted treatment. That is counseling plus counseling, which we call in psychiatric terms, at the better thing, psychotherapy. There's a difference between counseling and psychotherapy. Please understand, depression, we don't do counseling much. We do psychotherapy. Counseling is a passive process where I tell you to do this, you may or you may not do. Psychotherapy is an active process where we have a two-way interaction with the patient. Patient tells the problem, we diagnose a cognitive distortion, that is a maladaptive thought. We do cognitive restructuring, we alter these automatic thought, and the patient applies the process at home, comes back with a feedback. That's a more actively involved process that's called cognitive behavioral therapy, which is the mainstay of treatment of depression. Alone medication and alone counseling have limited results. Together, they have the best result. Okay. The next question which has come to me is, for generalized anxiety disorder, how much long treatment with SSRI? Again, generalized anxiety disorder is diagnosed when the symptoms are present at least for a period of 6 months. SSRI is the mainstay of treatment. Benzodiazepine are to be used SOS in acute management. If the patient is having a baseline anxiety controlled, after symptoms control, the guidelines say it must be continued for a minimum period of 6 to 9 months. Must be continued for a minimum period of 6 to 9 months. It has been observed that there has been relapses in after stopping of the treatment. That has been observed. So it general dictum says that it has to be continued for a period of 6 to 9 months. And next question is, may I prescribe tablet Epilex Chrono and Inderal tablet in case of migraine? Inderal is propranolol. Yes, that is for migraine prophylaxis. Epilex Chrono is valproate. Yes, you can use that for migraine prophylaxis. What is autism? Is it curable? The question asked is, what is autism? Autism is a pervasive developmental disorder of the childhood. It is not exactly completely curable, but the behavioral abnormalities in autism can be controlled to a lot of extent by behavioral modification techniques, and we have got some drugs which are approved for autism, like risperidone and aripiprazole. There are certain drugs which are approved, and that can be used. What is the best treatment for benzodiazepine withdrawal syndrome? Benzodiazepine withdrawal syndrome, if the patient is a benzodiazepine dependent on a short-acting benzodiazepine like alprazolam, etiozolam, the treatment is to substitute on a longer-acting benzodiazepine called chlordiazepoxide. Is depression curable? Answer is very much yes. The normal course of depression lasts for 6 to 9 months, and depression is a disease that attains full recovery and may have relapses. May have relapses. Okay. How can we observe mind of a patient from his behavior? That's a part of mental status examination. When we do a psychiatrist mental status examination, we assess the patient mood, we assess the patient's affect, we assess the patient's behavior. How to overcome professional depression? That's not exactly a term, professional depression, but if you are talking about depression in psychiatrist, if I understand by this, yes, the maximum number of depression cases reported among professionals are in psychiatrists itself. And it was very obvious that when you are feeling day in and day out, there are chances of burnout among psychiatrists. There are chances of them landing up in depression. In that case, you need to take a help from a senior psychiatrist than yourself. Do SSRI in depression need to be continued lifelong? Answer is no. No, they are not required to be continued lifelong. What is juvenile depression, sir? Childhood depression, if you are talking about, the depression can affect any age. Infantile is analgesic, childhood depression. Then we have an adolescent depression. So what is childhood depression? The child will become irritable, he will have anger outburst, he will not listen to the parents, he will have quarrelsome behavior, there will be school refusal in the child, and he will have somatic complaints like headache, etc. Next question. Is bipolar mood disorder curable or controllable? I will say better word is controllable. If you keep on giving the patient mood stabilizer, the episodes of depression and mania can be prevented. So bipolar mood disorder is controllable. Very good question. How often is bipolar depression diagnosed as simple depression? Very often. Because if a patient with depression comes and you do not take a previous history of mania or hypomania, it will be diagnosed as a unipolar depression. It will be diagnosed as a unipolar depression. That's what we say as misdiagnosis. So when a patient with depression comes to you, you always have to ask a history of a manic or a hypomanic episode, which will tell it is a bipolar depression or a unipolar depression, and the management is different. For unipolar depression, we usually prescribe antidepressant only, and for bipolar depression, we need to prescribe antidepressant plus mood stabilizer. In present scenario, mental health is prime because of our lifestyle, but it is people are not aware of this. Can meditation and yoga prevent such problem? Is the yes, then what it actually does to brain at a chemical level? Yes, it has been proven in studies that meditation and yoga are helpful in stress reduction. Yes, it has been proven that it's helpful in stress reduction. Is there a dire need to educate the so-called normal people of our society who behave unduly, humiliating the psychiatric patient and making rehabilitation very difficult? Later ones are human beings. There are give examples of exacerbation. This type of yes. So there is somebody who's talking about stigma and expressed emotion. How to talk to a patient of having a psychiatric illness, how to talk. We should not do the critical comments. We should not be over involved. We should not express negative expressed emotion. And don't say this that he has become psycho, he is visiting a psychiatrist, he has become psycho. These things lead to less of them approaching us as a psychiatrist treatment, as a psychiatric treatment. So yes, stigma is a barrier to the treatment of mental illness. Next question. Is the depressive episode of bipolar disorder different from organic depression? Okay. So is the depressive episode, Dr. Rohit, is the depressive episode of bipolar disorder different from organic depression? What do you mean by organic depression? That is a medical causes causing depression. For example, hypothyroidism causing depression. Clinically, it is very similar to a unipolar depression. Okay, clinically it is very similar to a unipolar depression. Only after doing the exam you know that this depression is related to other factor which will help you to decide whether it is depression due to medical cause is presence of that particular medical cause symptomatology. Is presence of that particular medical cause symptomatology. Next question. How to not to get stressed on having to explain several times to several members of the same family about patient's condition. This is also an important topic. How a doctor should communicate the patient's condition to the family members. There's a topic in psychiatry called breaking the bad news. You might have heard of so many cases of violence against doctors happening in and around. One thing I want doctors to know is how to break the bad news. Suppose you are an ICU in charge MBBS doctor and there's a patient admitted in your ICU who just expired, and you are about to go out and tell the family member that the patient who was admitted today morning has expired. Then the way of your telling will reflect the reaction of the family members and the attendants towards you. If you suddenly go out and say your son is no more, it automatically creates a rage in the family members. It automatically creates. That's why the primary method which the doctor should adopt is counseling and telling to the patient and the patient family member about the condition of the patient. Now, it's very common that we being medical professional, one patient is coming and there are 10 attendants of that particular patient. One by one, they come and they ask you about the condition of the patient. Once you explain, second time you explain, third time you explain, Fourth time, it is very likely that you might say, I have already explained this to the previous attendant. But for all of these attendants, the patient has been equally important family member. The attendants are going through an emotional turmoil. They are not able to adjust to the thing that one of the family member is suffering from particular disease. So you also agree to this fact that even if your family member is in this particular condition, you will inquire from the doctors. So you have to understand this particular thing that they will inquire. And not only in psychiatric practice, let's talk about in other practice like endocrinology, in ICU practice, all this. There are a lot of questions from the family members. As a psychiatrist, we face these questions very often. We explain to the patient and the attendant many times the same thing, still the patient doesn't understand. In that case, there is a burnout of doctors. You might have seen doctors getting irritable, getting angry, getting frustrated by telling this thing. And this is very, very normal thing to happen to doctors. The first thing which you require to have patience is patience. So patience is the ultimate thing which is required. So you have to be very calm and composed. What is labile effect? Raki Hari, what is labile effect? Rapid change of emotions with or without a stimulus. You might have seen that there's a person, when you crack a joke, he laughs aloud and he keeps on laughing, laughing, laughing. When you say something sad thing, he cries aloud and he keeps on crying, crying. The increased emotional reactivity is called labile effect. Is it SSRI is drug dependence? Less likely, I'd say. SSRI are less likely to produce drug dependence. Why the drug dependence is happening more? Because the drug dependence is happening more because SSRI uh, uh, along with benzodiazepine combination is prescribed by many people, which is leading to drug dependence. Okay. Next question. How to handle low self-esteem? I used to be very bold in my home and other places, but when it comes to working with superiors, I feel highly uncomfortable, nervous, and fearful, but wouldn't show it. But there's a constant urge in me to reveal out myself. Yes, low self-esteem at work. Low confidence at work may reflect your performance, may affect your performance, may affect your abilities to grow, and having a thing that hesitancy to speak among seniors is to an extent very normal, but you have to gradually develop that confidence. Suppose a person is not able to deliver a lecture to a 50 people, you don't say that go and deliver a lecture to 45 people and your fear will go. We tell them to him to do a gradual exposure, so speak in front of 2 people once, then 4 people, then 10 people, and eventually over a period of time you'll be able to speak up in front of 20 to 50 people. Other questions on Curofy? Uh, okay. So, any other question? A female patient is 72 years having BP was diagnosed with dysthymia since 5 years after the death of her husband. Is under medication but medicines are not helping her much. My question is, she is always restless, keeps on moving from one place to another. Calls the name of the family members who are dead and talks with them at the same time, remembers all of the family members who are alive. Patient seems to be quite active and maybe anxious sometimes. She is never seen in a depressive mood. Kindly clarify my doubt regarding this patient. Question asked by Dr. Archana. This case is that a female aged 72 years, high blood pressure, they were diagnosed with dysthymia 5 years after the death of her husband. After the death of her husband, a lady to have a psychiatric reaction is a grief reaction. If it is up to 1 year, that is considered more or less a normal grief. That is being sad, depressed, preoccupied with the thoughts of the dead one up to 1 year. If it is beyond 1 year, it is a pathological prolonged grief. DSM-5 says that it should be called persistent complex bereavement reaction. Persistent complex bereavement reaction, there are symptoms of anxiety, depression mixed. And as you said that she's always restless, keeps on moving from one place to other. And you are saying medicines are not helping her much. I'm not sure which medicine has been given, but according to me, the choice of medication for a 72-year-old lady suffering having depression and anxiety symptom with hypertension should be sertraline or SSRI. SSRIs are considered safer in elderly as compared to TCA, which have a lot of side effects, and SSRI should be considered. Benzodiazepine should be given SOS basis. This is the management of this patient from me, from my side. What is the role of ECT in depression? ECT is a reserve treatment. Question asked by Rake Hari. ECT is the reserve treatment for depression with suicidal tendencies, depression with stupor, depression with vegetative symptoms. Okay, depression with suicidal tendencies, depression with stupor, depression with vegetative symptoms, and severe intractable depression, sometimes depression with psychotic symptoms as well. Okay. What is mental block? Mental block, or if you mean to ask me about thought block, what is thought block? Sudden break in the train of thoughts. While speaking, you suddenly stop. Because sometimes you might have seen in Vivas, the students, while recalling something, suddenly are not able to recall. And they say that what has happened, especially in performance. When you're delivering a lecture, when you're delivering a talk, and suddenly, suppose I forget something suddenly while speaking, that's a mental block. It is mostly caused by anxiety related problems. Any other question? Okay, so before I conclude this particular session, I would like to say the final words. There are 5 take-home messages which I have for doctors in psychiatry. Number 1, you must know how to manage insomnia. And it's not that always you need to give benzodiazepine for insomnia. Better try zolpidem as far as possible, because zolpidem has less dependence than benzodiazepine. If anxiety is a cause of insomnia, then give benzodiazepine. Second, you must know how to detect a psychiatric illness. Behavioral abnormality goes for the psychotic spectrum, and neurotic problem in which the patient expresses yourself. Especially, please be able to detect psychiatric illness in a medically ill. Okay, and all the cases of depression need not to be referred. If the depression is mild, that is to an extent it is manageable, then you can manage it yourself. Moderate to severe depression are to be referred. Always be careful of the drug reactions of psychiatry. Antipsychotic, always be careful of fever and rigidity. Antidepressant, always be careful of diarrhea. Okay, and when to refer the patient? Any patient who is suicidal, violent, restless, aggressive, you're not able to, you don't think that you can manage it at your level, please always refer. And the concluding statement is that today we are here on this platform, Curofy. It's a platform for doctors to, and we encourage doctors to share their cases, share their views, and there are a lot of doctors on this platform, including myself. There are senior psychiatrists here, senior psychiatrists, MBBS doctors. By means of this platform, we encourage doctors to share such cases, and we'll be having much more these type of sessions, webinars. And I thank you all for this attending this particular session. I hope it is of some use. I'll be waiting for your share comments, and I'll be waiting for your comments and feedback on this particular session. See you someday in my classes, and thank you all my students at DAMS. So I'm signing off at Facebook right now. Thank you very much.